grief is a very natural response because as we live on this earth, we have attachment, whether we attach to our loved one, attached to a relationship, or attached to something, or attached to something that we really like a lot, right? So it's a natural process. If you go on with life, there will be attachment, there will be losses, and there will be grief, and there will be uh, uh, consequences that come along with it. Yeah, so a lot of our patients, when they are diagnosed with life-limiting illness, when we see them in our palliative care, they have already started anticipatory grief. So in the past MND patients that I took care of in most of them, I see that the anticipatory grief started at the point of the diagnosis. So I really like the model of care in It is a multidisciplinary care, and upon diagnosis by the neurologist of the MND diagnosis, the patient straight away on the same day, on the same time, referred to palliative care. So a lot of time we accept the patient in their anticipatory grief. Yeah, on the first encounter, they already expressed to us their reactions, and we have to hold their emotions. Yeah. With their impending loss. And I think the anticipatory grief journey for MND patient is really long. Why? Because we know that the median survival years for MND cohort, even in Malaysia, compared to the Caucasian cohort in other countries, other regions, they can live as long as 3 to 5 years, and we have take care of patients up to 8 or even 10 years. Yeah, so you can imagine the grief journey of this impending loss is really long. What's more with their family? Yeah, and I think the grief is not just losing a life, but it's also losing their freedom, losing their inability to move. And we know MND sometimes they have aphasia, they have dysphasia, and they have dysphagia, losing the ability to eat and drink and all these basic human needs. Yeah, so mourning is just a public face of the grief. Every culture, every people, they mourn differently, okay? And we should not judge, and we should not, sort of like view the way how people mourn based on their culture and their background, upbringing, with our own judgment as well, okay? So bereavement is just a period of time, the phases of the journey, which resulting from loss of death. So MND patients, when grief happens, just like any of the people that experience grief, when COVID pandemic strikes, a lot of us, we lost our freedom. We are confined to home, and even loss of job, employment, finances, abilities, and all this. Yeah. So I think even MND patients, they lost a limb, they lost a body part. And I remember very vividly, one of these patients shared with me, you imagine the whole day you have been lying on the hospital bed and you can't even move, you can't even scratch yourself, you cannot even, just a slight movement, you can't do it. So it brings a great distress to the patients, and the family who are seeing them also, they experience this, they lost their role, they have to take on multiple roles, and they lost their companionship. I think losing their spouse is really a kind of a grief that is really, really difficult. Yeah. So, and sometimes a certain group of patients, they get discrimination. They get a labeling kind of, based on their disease. We've seen that a lot in, disease that come along with stigma, isn't it? Like stigma of maybe retroviral diseases, HIV, or even social acceptance. We classify them into people of disability. So they lost that kind of social norms, acceptance as well as they go on with disease. And I think also a great part of it is they lose the sense of control. So what we do in palliative care is we really want to respect that person. We want to respect that people who are going through all this turmoil. We want to give them respect and privacy and dignity. And also we want to restore some sense of control. If they can't reverse the disease progress, but to allow them to have some control in decision-making, autonomy, and even to how they want their circumstances to be. Yeah. So that's why we talk about where do you want to be if your disease become worse, if you are at the end journey of your life, where you want to be. Do you want to be in the hospital? Do you want to be in the at home with your loved one? Yeah, and all this. Have you ever wondered why we grieve? Yeah. So I think grief is just not about darkness, negative emotion, all this sadness and all this. I do see hope, gleams of hope and lights in the tunnel. And sometimes we grow through the grief. Yeah. I think anticipatory grief has benefits. If you compare it to a patient who suddenly was diagnosed with this terminal illness, and imagine that it's as if, and then this patient passed on in a very short time. So the patient himself and or herself and the family, they do not have time to prepare the journey and or make arrangement for the time left. Yeah. So I think anticipatory grief do help to some extent to our patients on preparing for the loss and to prepare and go through, navigate and adapt to the changes in life. Yeah. And a lot of times they quickly go on to do their will, arrange for their spouse, their children, their family, arrange their will, yeah, and then finish the unfinished business. And if they have time, they would like to sit down with us. We can do a live review in a very simple way. And even at the bedside, there is a lot of conflict resolution. Yeah, can say thank you and apologize. I see a lot of my patients apologize to their family because sometimes they get very hot tempered, they get angry, they have anger in going through grief. Yeah. So the person who survived also, they have to acquire new skills. They have to master the life skills when their loved ones are not around, and they have to prepare for the role change as well. So anticipatory grief do have some help to our patients, as long as it is given the time and the space to start early. I believe this can be strengthened further for the patient who are going through difficult journey. So we grieve because we love, and I always find this very comforting for my patient family who grieve. Yeah, and I think it brings us to have a deeper understanding of the true value and meaning of our own life when we go through grief, and even the patient themselves. And it's a major forces, you like it or not, it drives the change in life. And I always emphasize to people who want to support grief is there is inner resilience. There is a personal resilience in each one of us. We just have to bring it out. We just have to support and walk along with them. And I'm sure that they have this resilience that push them through all this unpleasant journey. And it allows us to hold tight to our memory. So it's okay to grieve. It's okay to have memories back. It's okay to, talk about the persons who are not here, talk about what they do. And recently I have this bereaved family that shared with me. They laugh about this father figure that gone for the past 3 weeks. It is difficult, but they just they just shared the good memory together, and I think it's really healing the grief journey. So I think it's very important for the grief journey to start early. That's why we encourage people who want extra layer of support in grief and bereavement do refer to palliative care early. And I think each one of us here, we can help our patient to start the grief journey early. And you see that sometimes it's a winding road. Sometimes it's like a never-ending road. Yeah, so we're going to talk about prolonged grief. And grief is just very individualized. Everybody has different journey and different culture, different background, and a different ethnicity, religious beliefs. They just have different, not just different ways and patterns of mourning, but it is a different culture of grief altogether. You can see the color that they choose, the sackcloth. And then in the middle part is actually the grief, the people who are going through grief in Vietnam. So that's how they go and visit the grave. Yeah, I think all of us are familiar with Elizabeth Kubler-Ross grief cycles, from denial to anger to bugging, and then to depression, and then finally come to acceptance. Yeah. So this is the traditional ways of stages of grief. It gives us a very good foundation in our medical training about the stages that going through. And also it gives us a great understanding about why certain family behave. I'm sure you do recall some family, they suddenly get very angry. They throw their anger at healthcare professionals in the ward. Yeah. So your nurse will gonna, and then your even sometimes the doctors and the care the other family, the other caregiver will also have to accept all this emotion, frustration, anxiety, and anger. But as research go on, and as we know about models of grief for this past decade, I think it changes. The important thing to note is not everyone go through from step one, denial, to anger, to bargain, to depress, and then to acceptance. Sometimes it oscillates. Sometimes anger doesn't come. Sometimes maybe depress doesn't really come. Yeah. And maybe the shock is manifest in other ways, right? So I think the important is for us healthcare professionals to know, and then we provide the information and we communicate this with the bereaved and the family. And we knowing this, we can provide better emotional support and to provide an extra layer of guidance to them. And even for you who want to develop a bereavement support program, you can develop certain, maybe guideline and information leaflet based on this. And David Kessler, the disciple of Elizabeth Kubler-Ross, he came out with this book, Finding Meanings, and I think it's very comforting to read. And he said the 6 stages of grief is finding meaning. Yeah, and he shared that grief is extremely powerful because through the pain, we find the meaning of the pain, and what we're going through, it gives us a meaning, and this meaning is very unique to us. And if we can see the meaning, if we can see what is our underlying value and belief, we find ways to honor. Hopefully we have time, and we find ways, and even if we suffer losses, we tend to appreciate our people beside us more, isn't it? Right? So it gives us a lot of lessons, and I think it helps us to do this meaning, help us finding the meaning, finding ways, help us to find ways to make connections. And I think this connection is powerful, is empowering, whether the people who are going through it or the people who are supporting the grief. So this is the list and manifestations of typical grief reactions. And I just want to highlight here is sometimes somatic manifestations do come, like sweating, palpitation, tightness in chest, what else? And also like insomnia is very common, especially at the acute grief period. So once we recognize the normal, we will be able to recognize, so the situation and the manifestation that is slightly abnormal. And I think when acute grief happens, the yearning and with bereaved is so strong. So sometimes you will find that that brings some alertness in you. Sometimes you might wonder, is this person going to be commit suicide, and saying that want to go with this person? Yeah. So it's good that we pay attention to these things that are slightly we feel like is abnormal. Sometimes hallucinations also come, yeah. So I'm not sure whether some of you experience, if you have someone pass away at home, you walk by the room, yeah, sometimes you feel as if that person is there. And I remember this very clearly when Sister Ruby, our pioneer palliative nurse, shared with me. She has someone, this wife lost her husband, and when she support the bereavement phases, the wife say she go to the market, she can see the husband is there, she can see the husband is at the staircase standing there. Yeah, so all this visual and audio hallucinations sometimes do come, yeah, along the way. So I think a lot of the bereaved families shared with me, and they find a common theme that can describe how the grief strike them is like a wave. So sometimes it is just, tenang, like at peace, but sometimes the wave just comes, and sometimes it hits harder than before. So that is actually what we saw in the normal process of grief. We go through oscillation, and sometimes it's also very difficult to express their emotions. Many a times I sit with my patients and the baby family. They just tell me, they say, Doctor, tak tahu macam mana nak cakap. I don't know how to say, I don't know how to express. So I find this subject wheels of emotions is important, is helpful to me help my patient how to name the emotion. It is okay, completely okay. If they cannot pinpoint, if they cannot describe, we just sit along with them. We just journey along with them. Right. So this is the oscillations that we are going through right from the start. So we find that sometimes we go back to grief, we go back to the emotions, and sometimes we are okay, we can go back to our daily normal functions. Yeah. Sometimes we just oscillate back to the distress. So it's important to tell the family. Sometimes they will ask you, am I abnormal? Am I diseased? Am I having some pathological grief? So you can just reassure them, this is the task that they have to going through. Yeah, eventually they will strike a disequilibrium that will be tend to be more on the restoration side. So it is okay sometimes to just oscillate back to the emotion, the distress. Yeah. So I always emphasize to my team member is sometimes we feel that we just feel very helpless. We don't know how to help them. We see them in distress. We don't know how to comfort them even sometimes. Yeah. So I find it very comforting to reassure my team members is there is innate resilience in each one of us. So this is the model that we go through. We go through in Safe Space project, where we founded to support those going through a complex grief in COVID pandemic. So you can see that it's a different level of support. We utilize the resources in the community. We put out the resources of NGOs and volunteers. And we use the fundamental principles of psychological first aid, yeah, across all the levels. Whether you are a psychiatrist, you are someone who are trained to have provide grief therapy, or whether you are a lay volunteer, whether you are someone who are just happen to be neighbor or family to someone who going through extreme distress in grief, you can apply the psychological first aid principles. Yeah, you can even get the resource from WHO guide. There is a lot of PSA training around for the field workers, and also from our MHPSS group, our mental health social support group. So the concept is to just, when disasters strike, when grief happens, when there is a complex loss, yeah, it's just to provide a psychological first aid in the sense that provides safety and comfort, and to stabilize the chaotic situation, and to provide important information and practical assistance. So that's why this practical assistance and to connect with familiar social support is what we can do, each one of us here, to fulfill the basic needs. So before we apply, sophisticated psychotherapy or grief counseling, what we can do is just simply provide a safe shelter, provide a secure place, and even provide basic needs like food, give them a glass of water, pull a chair, let them sit down, and just support their distress in emotions with your empathetic and your compassionate action. So this is what I draft for the protocol in how do we apply PSA in safe space. Yeah. So along the way, we start with look, listen, and link. So as we look and as we observe, we don't have to do a lot of drastic things. We just have to observe that we make sure that person is in a supported and safe environment. And along the way, look for red warning signs. Example like suicidal ideation, self-harm, substance abuse, tendency to harm others, and tendency to harm. Yeah. So if they have, then we quickly jump to the link to link them to a specialized care. You can refer to your psychologist colleague or a psychiatric or counselor colleague, yeah, knowing that you are not alone in supporting this, and to utilize the team approach and give them the physical need and provide them the social need. So I guess that's why a lot of grief, they go through the normal path, as in people go through grief just with the support of their community, their family, their neighbors, and their friends. So as we observe, we also observe what type of emotion and distress that they're going along, and acknowledging that this is normal, and allow them to ventilate, allow them to cry, allow them to have space to express their distress. So we're going to talk about prolonged and dysfunctional grief. How do we recognize it as a healthcare professional? So listen is the main gist of it. So pull a chair, sit down, and you will see the different. This is really proven by the some randomized control trial and evidence-based. You pull a chair, you sit down, telling them that I give you ample time and I give you my full attention. Just tell me, just take your time, go ahead. Yeah, I'm listening. Compared to you just standing there and then you just, just listen at the corridor. Yeah, it makes some difference. Yeah. And it helps you to navigate and perhaps penetrate to a deeper conversation more easier. And of course, if we want to listen and understand, we put away our own judgmental thoughts. And it is not our perception. It is not how the way we see the situation, how the way we see things. It's us putting ourselves in the shoe of that person, seeing them how they view the circumstances and situation, yeah, from their viewpoint. So that's very important. And we always tell our volunteers in our training is to refrain from giving your own opinion and even refrain from sharing your own experience as well. And just respect that person as a person. Forget about that person. Sometimes you just have to forget that person as a patient. That person maybe is a father. That person maybe is a husband to someone. Yeah, the person maybe is someone working all this year with the occupation. So just to understand how this person is, and of course to respect the privacy and the way that this person choose to express the emotions, and what are the things that they choose to confide in you, and some things that they rather keep to themselves. And I think it's powerful is to give some reassurance on some positive strengths. So help them to see those hope and help them to see those, those moments and those, I call it like maybe positive moments. Yeah. And even for you to be present there is really supportive enough. You will hear them come back and feedback to you. Thank you very much, doctor. Thank you very much to you who actually listened to me and be with me at that time. Yeah. Right. So it's also good to admit to them. And sometimes they ask you, how long do I have, or how long you think, doctor, will my maybe my loved one last? Yeah, sometimes it's okay if you do not have an answer. You can just admit to your limitation, and you just say, yeah, I don't really have an exact answer to that. Yeah, so don't feel that you have to solve every problem. Most of the time, in fact, I think 80 to 90% of it, we just cannot reverse their irreversibility state. So if I think it's also important in safe space, we compile our link and our resources. If let's say we know that a minor or children is facing some abuse and their safety is compromised, so we know how to link them to the agency. Yeah, I think it's good that you know within your resources who you can run to and who you can reach out for support. Okay, and I think if you come across those who are having psychiatric disorders, like major depressive disorders, and sometimes grief do unmask their underlying psychiatric disorders, like maybe unmask their anxiety disorder, unmask the depression disorder that is maybe in remission in the past. And if the death circumstances is rather traumatic, you will find that it mimics the PTSD kind of manifestation. We're going to look at all this different, yeah. But if you have patients or family who are, you know that they have these underlying disorders, and you are quite sure they have their diagnosis is geared towards all this rather than it's going through the normal grief process, all these psychiatric disorder take precedence over the pathological grief that we're going to talk about. Okay, so you refer them to the necessary channel and let them take their therapy and their medication. So this is just the theoretical task of grief counseling that I think the grief counselors or even our MHPSS group use. So you notice that the stages are quite more the same of the model that we learned from Elizabeth Kubler-Ross, initial state of shock, and then going through all this, experiencing all these emotions, and then reintegration, restoration. We call it like maybe healing, maybe finding meaning stages. Yeah. So the grief task is, and the process for someone to process their grief is to work through all these stages. Most of us, you can see that the general population, 60% of it is just low risk. They do not have to see grief counselor, and only a small portion of them, maybe they have a complex grief issues, especially those cases that have traumatic death, or maybe death at a very young age, death of children, and then like suicide case, and all this that can lead on to a very complex grief that we need to channel them to healthcare professionals with specially trained background. So even at the level of moderate risk, yeah, you'll find that there is some inventories from the research and some scoring to classify them. But I think generally we will be able to identify. And we have started a peer support group in COVID-19 in safe space. And recently we had done a bereavement support group for people who lost their loved one due to cancer, and during the COVID pandemic for bereavement support group in IKN, in Institute Cancer Negara, and also within our palliative group also we start to provide all these peer support groups. Because I think also evidence show that there is certain strength for peer support group. So the similar group of researchers in Australia, they compared the MND cohort to the general population of whether or not they will suffer from higher risk of complicated kind of grief. The finding is, yes, you see that a lot of them are grouping under the moderate kind of risk. So perhaps there is a certain usefulness if we can provide some peer support group or some volunteer-led group that instead of going through the normal, going through grief and support with their own circles of families and friends, perhaps we can offer some sort of extra layer of program, peer support group. Yeah, so you find this in US in the veterans group. A lot of, like those ex-army, they go through a lot of traumatic grief, PTSDs. So they find that this peer support group really, really can empower and help people going through grief better. So let's talk about prolonged grief disorders. There's many other names for it, like pathological, persistent, complex grief, traumatic grief, unresolved bereavement disorder, or even chronic grief. So the characteristics is it is a prolonged kind of trajectory. Remember, I say that the grief journeys is individual. Sometimes we take some longer time to come out of our grief. Some people take 6 months. Some people even take 10 months, 11 months, 12 months. So it's really individual. But if you found that the patients have a projected and protracted kind of grief that is maladaptive, and this thought is just maladaptive and is causing dysfunctional behavior, emotions that are very difficult to regulate, and plus minus some superimposed serious psychosocial problems, then perhaps we need to refer them for a better diagnosis. So this is the DSM-5 criteria for prolonged grief disorder. You can see that. And I think the important timeline is 12 months. I think some research and literature do suggest as early as 6 months, but I think that's just way too early. Remember, even if we go through normal grief, sometimes when we integrate that grief into our daily normal life, we find that sometimes we oscillate back to the memory of the bereaved, in a different degree of maybe emotions that come along. So I think 12 months is a good timing to really let us maybe observe within this 12 months and how the grief journey go along. And it's also good for those who want to form their bereavement support system and program. Say our bereavement support system in our palliative unit. We always follow up the bereavement we do bereavement follow up for 6 months and even 12 months, just to screen them through if they have any difficulty that we need to provide support. So there is some major and minor symptoms, but I also want to stress that some duration and intensity of grief response is really, really different according to the expected social, cultural, and religious norms of that individual person. So I think that in Indonesia, there is a religious and cultural custom that I think is in one of the village. When their loved one passed away, they make the corpse into mummies, then they worship, and then they put it in the house, living together. So that's the cultural variance of this group. So we should respect that, and we should actually provide some leverage to as when we diagnose and when we observe certain grief. So I think it's very similar with typical acute grief and the PGD, prolonged grief disorders, and especially when during the anniversary, the symptoms, the grief gets more intense. So this is the month of Ramadan, and a lot of families shared with me that this is the first Ramadan that their loved ones are not with them. So it brings on, the anniversary brings on the intensity. But I think the PGD is it is unrelenting. It just never ends, and it's projected, and it sort of impacts the functions in a way that is, I think, will be very striking to us. So they still go through perhaps certain level of normal grief process, but it just gets projected. The winding road just seems to never end after 12 months or longer. And I think being depressed is very common when we are in grief, and we tend to isolate ourselves. socially withdrawn. Yeah. But I think the ruminations of depression is really ruminate and focus. They turn around at the worthlessness and their own self. They have their anhedonia, loss of pleasures, and they cannot don't want to step up to the world. But for the PGD itself, the sadness and the depressed is more centered upon the loss of one, and it's just very characterized by you really want to yearning and longing to be with that person, including their guilt is to blame themselves, yeah, and also the suicidal behavior and ideation is very common. So if you find that your patient has a suicidal plan, you quickly channel them to suicidal. You quickly have a suicidal prevention plan for them. Yeah, so I think in the group of suicide prevention group, they teaching us, guiding us on what to do. So just refer and run to your MHPSS group and say that this patient needs referral. Yeah, and what about PTSD and prolonged grief disorders? Along the way, I do sometimes I do wonder, sometimes some bereaved family, they just keep on having these flashbacks of memory of the death circumstances. So sometimes I do wonder, could it be PTSD, post-traumatic stress disorders? I think they are very hyper vigilant to threat. Even a small triggers can brings on a very exaggerated kind of startled response, and they do have nightmare and intrusions of thoughts based on the traumatic event. But for prolonged grief disorders, I think the yearning and longing is more towards, searching for the reminders of that disease and focus upon the disease to bring comfort. So I have many bereaved family, and even I myself had gone through this, So when my grandma passed away, I kept her stockings, the last that she wear. And lately I also have this a spouse of a wife that shared with me. She kept the shirt that the husband wear in the ward. So I think as time goes by, this will get less and less. But if you find that after a period of long time, after 12 months, that could ring a bell that you might need to pay extra attention. Okay, so this is what suggests from qualitative studies of caregivers group in Australia. They feel that they need more bereavement support. They want more information. They want more referrals linked to, perhaps they think that they need more counseling. They need peer support, and especially those living in rural and far away areas. Yeah. So I think in this era, we can utilize virtual support group. We find that it's very convenient. In COVID-19 safe space support group, we did sort of like a national meetup on this Zoom, and even the bereavement support group now, we are doing hybrid. People who can't travel far for a physical peer support meeting, we do it online. So these are the best practice in bereavement support. You see that all of this is easily can be done by each one of us here. We utilize the resources of our community, and I believe that the spiritual religious belief and practices do play a part in the spiritual aspect of support and strengthening, and even sometimes with just very minimal intervention, yeah, but with high level of practical support to the bereaved, and encouraging them in narrative therapy, like talking, thinking about, encourage them to write down a letter, encourage them to maybe can just, children, they can talk to their parents who are gone, just at night, just like this. and or even bring their their report card and write a letter to the grave, put it to the graveyard, and things like that. But the common theme that a lot of our bereaved family they share that the most challenging time and most difficult time is when they are alone. Yeah, so I think grief do put us into a certain loneliness, a certain level of loneliness. So that's why the network of support is really important. Peer support is just that the systems of giving and receiving on the key principle of respect and shared responsibilities and mutual agreement of what is helpful. So basically, it's just to bring along people who are going through the same similar kind of experience, that they support each other in a very close and secure and safe space with respecting each other. And I think social support do play a major role in combating loneliness and social isolation. Yeah, we can, if we can't provide emotional support, we can give advice and information and practical assistance, and even to sit along with them for the narrating process. So it can result in good health and positive outcome. So these are some of the information leaflets that we provide to our bereaved family in hospices and also in palliative care setting. So all are very simple things. You can express, and through drawing, even talk to an empty chair, and even when they go through the conversation itself, they process that grief. Yeah. So just send them some message and just say, if you sometimes you don't know what to say, you don't know how to say your condolence, you just remind them to get some rest, get some space to sleep, and get some, even they don't feel like it. Yeah, just remind them to take care of themselves and encourage them to walk out of the isolation. Yeah, this is a book that I recommend from Catherine Mannix. I think you can get it from Google Playbook. I think it's about 60 ringgit plus if you get through electronic book. So it talks about how do we navigate through all these painful and tender conversations. Yeah, so you can read, and I think a lot of us, most of the times, we just have to just offer our presence. And sometimes it's not easy. It's certainly very, very difficult to sit in a very difficult conversation, to have someone to pour out their emotions and, share their difficulty to you, especially in the situation that we feel that there is no way that we can reverse. Grief and loss, it just happened. We can never bring back the persons who have gone. Yeah. So I think it's important for us to recognize that, recognize that it's very challenging, that it's very difficult. Yeah. So, for example, I actually going through a grief in my ward right now. I have a very young 23-year-old girl who is dying in my ward due to Kuchenberg tumor, and she had this complete bowel obstruction that we try everything that we can't really reverse, and we can't really I just feel very helpless. And I think a lot of time we will feel that the state of helplessness, as in this person in the hands of with an empty hand. You just don't have anything to offer anymore. Okay, so and then I come to realize as I go through this grief, I also realize that my team members also going through the similar kind of grief as we take care of our patients and their family. Imagine how the parents go through. Imagine how her siblings go through this journey. So at the end, I just realized I just have to be there. I just have to hold that emotion. I just have to hold that and let the process of grief takes its course. Yeah. So true enough, sometimes I see little smile on her. True enough, I see sometimes little relief of comfort. Maybe the abdomen gets less distended, and maybe I started drip that can help her. Maybe she want to draw. I let her draw in the ward. I let her do her coloring. So all these little gleams of hope and meaning making will come along when we brace ourselves to sit in this state of helplessness, in this state of difficulty. Okay, so I think it takes a great courage lah, for me and you to be there, and also it takes a great courage for our patients and family to go through all this. So you might realize that you form a good friendship with them. It's a relationship-centered kind of interaction. Yeah. So it requires to be empathetic. If you put yourself in the shoes of that person, you certainly will feel that person's pain. You certainly will feel that that emotional resonance that will come onto your side. Yeah. So I think all of us we are being we are called to be compassionate, then it is compassion actually is an action coupled with love, and is kind of a selflessness. Sort of we put our needs aside and we go and help and immerse ourselves in that person's suffering and try in our little way to relieve the suffering, yeah, in a small little way. So I think this coming to an end part, I also want to remind each one of us, we work in a team. So I'm sure every one of us experience grief when we take care of our patients, especially when we walk with MND patient and their family. It's going to be a very daunting journey. So do look out for yourself and look out for your colleagues, your team members. Yeah, sometimes you just have to spend some time and some space. Yeah, give space to yourself and to your team members. Listen to them and to really take note of their grief that they are going through.